Sorry about that, guys. I don't know if it's my side or Dr. Reed's side, but I'm going to get him back in the room right now. Um, yeah, sorry about that. He was doing very well a while ago. Sorry about that. Yeah, I don't know. That might be me. Third world problems.
I don't think so. It
third
was
world,
probably
third world Wi-Fi. Third world Wi-Fi. Yeah, you were saying the last thing I heard about you're making a comparison about andropause to menopause and the men. Why men and why women can't get it?
yeah. I mean, I think the thought. I mean, because you got me on my soapbox, man. Is advocating and empowering women that both of us have been doing for years. But there's no way in hell that it is appropriate to tell a woman just to age and leave her alone. And here's a little primrose oil. Hormones are safe. I mean, if you're scared, like I said, they could see you. They could do fractional CO2 laser. It will make sex not only tolerable but pleasurable. You can add estradiol to the vagina combined with Femilift, and that's synergistic. That's not 1+1 = 2. That's 1+1 = 3. And so combining those two can really help. ACOG was released a statement stating that it's safe to do vaginal estradiol cream to the vagina. Is no risk to breast cancer. In fact, if you're on hormone replacement therapy and estrogen alone, you're actually decreasing your risk for breast cancer. So I don't agree with the old zombie adage that estrogen is going to lead to breast. Estrogen is going to lead to more vibrant life, more fulfilling life, and fulfilling relationships and building stronger families. I mean, there's no reason that women should be having this, and I think that there's a lot of options out there to help women remain sexually vibrant until they die. My
Definitely.
patients that are in that I supplement with testosterone therapy just so they kind of keep their sex drive going, keep their energy going. So there's really no reason not to do hormone replacement therapy.
I agree. You opened my eyes last night to a lot, and it's something I'm definitely going to start to explore because again, unfortunately, like I've been offering a lot of women have been coming to me because of the whole O shot. They want to revitalize their sex life. So
Mm.
a lot of women have been coming for the O shot, and I combine it with a high food. And as I said, I recently got the fractional CO2, and I want to do some work with that as well. So I mean, I find the O shot. What's your experience like with the O shot? You've been doing it longer than me. What has your personal experience been with it?
So the way we do the OSHA is we price it so that every woman gets 2 shots. With
Okay,
one
interesting. Over
one
what period?
with one shot, not in my experience, you're somewhere in the 50-55% range in success in increasing arousal, helping with improvement in stimulation and sensitivity. You take that with 2 shots, you're somewhere in the 70-75% range. And so what I've done is price it so that women are able to get 2 shots and increase the probability of having vaginally activated orgasms and at least having improvement in stimulation, sensitivity, and even sometimes arousal and sex drive. So I want them to do the best. I don't want to charge them 2 separate shots to get them to 75%. I've priced it so that it's right in the between, so that they can get 2 shots for the one price. And so with that, we're around 75% success in achieving vaginally activated orgasms as well as increasing sexual stimulation and arousal.
All right. Do you give these shots at the same time?
No, we give one shot, but one first in the clitoris and then into the G spot.
Yeah.
Then they return in 4 weeks because, as you know, platelet-rich plasma, it's going to take about 3 weeks for it to really settle in. Now, some women experience
Within a week?
changes within a week or even that day because of volume, because you're introducing so much volume. So you're introducing volume into the clitoris, you're introducing volume into the G-spot. So when you have all that volume that you've just put in there and they go home and they test it out, I mean, the G-spot area is larger, so they're going to experience maybe a little bit more pressure on their G-spot, which in turn would help with arousal, and hopefully they achieve a vaginally activated orgasm. However, by time, it usually takes about 3 weeks for the platelets, the activation to collagen growth, blood vessel growth, that actual area getting larger is going to take about 3 weeks. So that's kind of the why we have them come back in 4 weeks, to build upon what is already there.
Dr. Reed, you're teaching me some stuff right now, you know, because I have found I don't offer the O-shot alone at all. No, I find that the O-shot by itself, you don't get the results that you want by itself. Like I would say about 50 to 60% of the time. So every time, it depends on what I'm treating, right? But every time I do the O-shot, I combine it with a HIFU. As you mentioned something earlier, it's synergistic. It's not, it gives it works, it makes it work much better. So I always, like when I charge a patient, I say, you're not just paying for the O-shot, you're getting at least one course of HIFU. And if I'm treating like stress incontinence, I do it over 6 weeks. I do two treatments every 2 weeks for 6 weeks plus the O-shot, and I get very good results with that. But no, you're opening my eyes to some more to giving them more O-shot. I didn't know that, you know. I didn't know that at all.
I mean, there's evidence-based medicine out there. I can't remember exactly where it's done, but it's in Europe. A study was done where they showed that with the O-shot, that 2 shots were better than 1, 3 were better than 2, 4 was better than 3, and 5 was better than 4. But my goodness, I mean, I never would. If someone was not responding by the second or third shot, I wouldn't go any further than that. But the studies did show that the more shots that they were given, the greater likelihood they were successful at achieving a vaginally activated orgasm.
Okay, I have a question for you. And a patient came to me a couple of weeks. I gave her the O-shot, and she told me it failed. And when I was talking to her, I was like, I have a post-op questionnaire. I said, how is your lubrication? Say it's increased. How is your sensitivity? It's increased. How is your libido? It's increased. The only thing that she didn't have was the orgasms. And I told her that we can't call this a failure, you know, because you did get some improvement of symptoms. What are your thoughts on that? You know, when counseling the patient where that is concerned, is it a failed O-shot because she didn't get the orgasms? Or is the successful O-shot because she got things that she didn't have before? The sensitivity, the lubrication, the libido, increase in libido. What's your thought process on that?
My thoughts is that, yes, the O-shot's going to help you, and it can help you bring you over the edge. But there's a lot of other things that's going to influence your ability to have an orgasm. You could have a great G-spot area been plumped up from the O-shot. The clitoris is more responsive. But if you're thinking about something other than yourself and being in that moment, you're not going to orgasm. If you don't feel secure in your relationship, you feel like things are going on and you're doing this in hopes of kind of keeping things together, you're probably not going to orgasm. If you have a lot of stress going on, if you're unable to focus, if you're totally focusing on the idea, oh my goodness, is it going to happen? Is it going to happen? You're not going to have an orgasm, despite the fact that you have a plumped up G-spot area, you know? So there's other factors that's in there. So any patient that, you know, we talk about orgasm, you want to talk about the gamut of things, because maybe it's just counseling that they need. Maybe they just need to talk. Maybe they just need to do self-exploration. There's a lot of different things that you can do to get to an orgasm. O-shot is one other vehicle to help you get there. And so that, I hope that answers your question, in that, yes, you can have O-shot. Yes, you can have arousal. Yes, you can have more lubrication. Yes, when you're excited, the G-spot area is larger, but there's still other factors that can interfere with your ability to orgasm.
I fully agree with you, and I work very closely with a sex counselor as well. You know, so everybody is different, and you have to individualize your management. I say, well, we got a success. You really wanted the orgasm. Probably something else is going wrong. You know, let us. I've done my part. You know, you may have a problem in your relationship, and a lot of women. It takes a lot to break them down, because some women are very open with what's happening in their life.
Mm-hmm.
Some women are saying, boy, this is what's happening in my relationship. If you're having some breakdown in your relationship, that can affect your orgasm or your ability to orgasm. Because I always tell patients this, and you can agree or disagree. Orgasm and sexual gratification is 8% mental and 20% physical.
Oh, I 100% agree with that. 100%.
Yeah. You know, so if your brain is shut off, whatever aspect, you could be having sex with your husband, your boyfriend, and like you just remember in the time he cheated on you, you're not going to orgasm.
Absolutely. You're not.
You're not going to orgasm. We can give you 2 O shots, we can give you 3 O shots. You're not going to orgasm because your brain is shut off. You know, that connection that you need to orgasm, it's gone.
Absolutely. I mean, we're preaching to the choir as far as that.
Yeah.
Listeners need. And you're right on, Jamaican King. Right on. Keep pushing on.
Yes, Davis Quinn. Yes. So you mentioned last night when we were talking, and you mentioned it earlier today. You do all your procedures under local anesthesia. You want to explain that? Because that's a big thing, guys. Because I don't do all my procedures under local anesthesia. I don't do my vaginoplasties under local at all. I'll do my labiaplasties on the local, but not a vaginoplasty. You want to explain to the listeners what local anesthesia is and how you go about doing your procedures?
Yeah, so local anesthesia is wonderful for several reasons. Number one is not as expensive because you're not paying for an anesthesiologist to put you to sleep. Number two, once the procedure's over, you can go. You can go home. You can be dropped off. You don't need anybody to sleep with you and stay with you at night for fear of what general anesthesia may do. But in regards to vaginoplasty, one of the things is that oftentimes I can get you tighter under local anesthesia than I can general anesthesia.
Really?
So here's the reason why. So number one, when we take bites, I shouldn't say bites, but we take suture, and we are bringing muscles into the midline, we're going to be, we try to be as aggressive as we can to bring more muscle into midline to develop more of that shelf. So if they're under general anesthesia, the concern with levatorplasty, that's what we're talking about, is bringing muscles into the midline, is levatorplasty. As you know, in residency, we're trained to avoid levatorplasty because of fear of injury to nerve, right? And having chronic pain afterwards. So while I can be very aggressive locally. So if you're local, you're speaking to me, you're talking to me. So I can be very aggressive in the sutures and the amount of levator muscle that I bring in together. Because if I have incorporated any nerve in there, you're going to say, well, ouch! And I'm going to remove that suture, and then I'm going to retry it again. The other thing, as you know, when you're in there, if there's a large rectocele, it is very difficult to get along the paravaginal wall, right? And now you're over against the wall, and now you've gotten that rectocele out of the way. Now, where am I going to put my suture? If I put it too deep, am I in the right spot? Guess what? I can say, Shirley, squeeze your muscle for me. She squeezes it. I feel it. I know exactly where I need to go. So the combination of those two things allows me to get you tighter, because when you're under general anesthesia, the only way you're going to know if you've incorporated any nerve is when they wake up and they're in pain. And so now you have to make the decision. Do I do pain medication? Do I offer some kind of physical therapy afterwards? Do I go back to the OR and try to figure out what suture is bugging her? So what do we do?
The last one I don't like.
Yeah.
The last one I don't like.
We don't take aggressive bites when we're trying to bring those muscles together because we don't want to incorporate that nerve. I can do it and get as much of tissue and muscle together because I'm going to have response from the patient. The patient is going to let me know that I have great suture placement and I'm not hurting her nor will I have problems with long-term pain syndromes after the procedure, which can happen when you're having vaginoplasty with a surgeon who's not very savvy in doing the procedure. So being able to do it under local anesthesia puts me far advanced and my ability to make the vagina tighter.
But Vagina Whisperer Las Vegas, he's a big cosmetic GYN in Las Vegas. He says combine local with Valium and a narcotic. What's your thoughts on that?
Yeah, so I mean I totally agree. So what we usually do is, as soon as you hit the door, we give you lorazepam, which is Ativan. Once the Ativan, about 30-40 minutes later, you're more relaxed. You're more in a place that you're less anxious, and we start the procedure there. So then when I'm giving you injections, you're not feeling it as much. We also give BLT cream, which is benzocaine, lidocaine, and tetracaine. That's given as soon as they hit the door, and then Ativan is given. Then we do a pelvic exam, making sure we're both on the same plan, making sure that both are agreeing on what is to be done, because it's her body. I'm just the tool to be able to carry out the desires that she wants, right? And then we put her in the procedure room. By then, she's in a good state of mind. 2, the vagina or vulva is a little bit more numb, so when I give local anesthesia, they don't necessarily feel the poke of the needle, but they still feel a little bit of the sting as I give them the anesthetic. Once that has happened, it usually takes about 15 minutes to get everywhere kind of globally numbed so that I can do the procedure. They sit back and relax. I have patients, they watch Netflix. To the nurse that's taking care of them. Sometimes they have a family member with them.
Or you allow family members in the room with you?
In there. While I'm operating, a lot of times the spouse will come over my shoulder and, what the heck is that? Oh, God. And they go back over. But it lends itself to an environment that is just pleasurable for everyone. And it also has, I feel, greater outcomes because I'm able to get them tighter.
Mm-hmm, mm-hmm. What kind of solution do you use? The tumescent solution? What do you do?
Yeah, for your solution is a combination of tumescent solution as well as injection into giving different aliquots along the levator plane, and using tumescent solution. We use bupivacaine combined, buffered with bicarb, and then of epinephrine. The bicarb is given in hopes to decrease some of the burn when you do inject the anesthetic. But the combination of the 3, we're able to do everything under local.
You do that with your labiaplasties as well?
Yeah, nobody goes to sleep. They come see me, no one goes to sleep.
Oh, I mean, I only do my labiaplasties on the local, but I don't think I have the guts to do a vaginoplasty on the local, Michael. I really don't think so. I don't know. I'm afraid.
Come on down. Come on down. We'll show you how we do it, and you can decide on your own, But
I'd appreciate that.
But
it's so. I mean, my patients are usually awake because I do a saddle block, So they're awake and I'm talking to them, but I'm in the OR, because I don't have a big OR in my office. I just have a small little operating room, where but I can't put people to sleep in my office. But I don't know. I'm afraid. I'm sorry. So how do you deal with the bleeding? If there's a bleeding and the patient is awake, and you have an assistant with you?
Yeah, I have an assistant. I have a surgical scrub assistant. I have my nurse. I have suction. I have everything that I need there. It's just all about slow, methodical, plotting surgery. You know where the spaces are that you need to avoid. You know where the places that can get you into trouble. So when you see those, you plan, you think, you're constantly in motion. That's why we love surgery, because you're creating, and there's artistry and there's problem solving at the same time. So one, you just have to be confident that you can fix whatever comes your way. You can fix it. You've been trained. You're overtrained. You know how to handle this. So it's a matter of being confident enough and being supervised for a few of them. And then once you've done that, you'll never turn back.
I said, Vagina Whisperer Las Vegas saying the same thing. I mean, what I realized from the ISCG conference earlier this year, that everybody does their vaginoplasties on the local. I felt like a small fry. I was like, oh my God.
It's not everybody. There's maybe 15 people in the United States, maybe 20, that are doing it all under local anesthesia. Not everybody's doing it. I mean, you have to be trained to do it. 2, you need a little supervision so that you've gotten the right places. And 3, you got to be confident enough to be able to do it and plan ahead.
But Michael, you don't find the planes are a little bit distorted when it's inflamed with the anesthesia?
Say it again?
You don't find the planes are a little bit distorted when the anesthesia is infiltrated there in the vagina?
That's one of the advantages of the local tumescence, because you're putting it between the vagina and the mucosa. So you're fluffing that area up. So you're making that plane even easier to work your way through it. And that's part of it. So you're putting local tumescent in the vagina, right? You're going all along the vagina where you're going to work. And then you're placing aliquots of anesthetic along the levator planes on both sides, as well as the muscles of the perineum. Once you do that, they're frozen. They don't feel anything. They feel pulling and those kind of things, but overall, they do wonderful.
Yo, I really need to, you planted a seed right now, and I have to try and explore this option. I really have to try and explore this option, because as you know, I mean, that anesthetic price is so much more.
Yeah.
That general anesthesia, that spinal anesthesia price is so much more. So like when patients come to me and they just want a labiaplasty, I say, what's your pain tolerance like? We can do this in the office, we can do this in the office. And, once they agree, I find the majority of them tolerate it very well.
Absolutely.
I find the majority of them tolerate it very, very well. Once but I find, especially when it comes to the labiaplasties, you have to mark carefully before, because once you inflame that area, everything is distorted.
Absolutely.
Everything is distorted.
That the hardest part to labiaplasty is the design, by far, is the design. And looking at the patient's anatomy, listening to her cosmetic desires, and then coming and understanding the flow of everything, and then drawing those lines and being confident in those lines. That's the hard part.
Yeah. I mean, that draw is the most important part of the surgery. Like I'll be rubbing it out over and over. I say, this is not right. This is not right. And then sometimes some patients will come, Doc, take it all off. I don't want anything.
Mm-hmm.
I don't mind those. That's easy.
Right.
But some patients will be like, I don't want too much off, Doc. Just take off a little bit. And like you'll mark it. Like when they come to the office, I'll mark it and I'll show them how much you want off. Like I saw you with a video and you have the patient with the mirror, and they're looking and seeing. I like that. I like that. I saw that,
Yeah,
they have a mirror and they're looking at it.
Yeah, it's their body. This is their design. This is what they want. These procedures are done for the woman. It is for her. Like I said before, I mean, man, we're just happy to be there. If we're there, we're so this is all about the woman and her feelings and her desires. So you have to incorporate her. She has to be a part of it. She has to share with you the bothers, and she has to look.
Or when she's awake, she can see what's going on.
Absolutely. Yeah.
So do you do any other procedures other than labiaplasties? Do you mess around with any majora augmentation or reduction or suprapubic lift, anything like that?
I do labia majoroplasties. Those are always fun. They have striking changes after doing it. That's done more kind of like the tummy tuck, outer lips, the big lips, to kind of flatten them, because a lot of times when women stand and they're looking between their legs, they might see the little dangle, I call it. Quote, dangle is there, and it's bothersome. A lot of women are exercising. They're doing CrossFit. They are in shape, and they look down and things look flat and wrinkled and kind of dangling, and they don't want to look at that because they feel far better than what they're looking like. And so labia majoroplasty is a wonderful procedure to be done to kind of regenerate, kind of restore a youthful, perky appearance to the vulva. So labial-majoroplasty. We do perineoplasty. I work with women with lichen sclerosis.
PRP.
You know, we do a lot.
Yeah. I do you use the knife or the laser for your surgeries?
I use a radio frequency needle.
Radio frequency needle.
Elman radio frequency needle. Just needle that vibrates super fast.
That's what Red use. Red.
Yes, absolutely. That's right.
Yeah.
Red is a big user of it.
Yeah, he's a big. I mean, I met him once in England in 2019. I'm sure he doesn't remember me, but I know he's big on the radio frequency. Okay, you know, I'm Matlock trained, so I use a laser.
Yeah.
I use a laser, and it's a neat device. You know, it's a neat device. But I mean, like there are many, as we were talking last night, there are many ways to skim a cat. You know, and I find that just generally in a big part of our residency, and I'm sure you can agree, and I know all my other colleagues online can agree as well, you take bits and pieces of everybody who you have interacted, every senior resident, every attendant, every consultant, and you put everything together. And as long as you're not doing any harm, that's your technique. There's no wrong way, there's no right way. As long as the patient is not in harm, and as long as you're doing what you're supposed to do, that's your technique.
Yeah, that's your technique. I mean, I totally agree. I will say that the thing that is really a problem with labiaplasty, and not so much vaginoplasty, but labiaplasty, is that picking the right surgeon. You know, there's no if you were going to learn how to do rhinoplasty, right? You're going to fix the nose. You'd have to have so many of them supervised. You'd have to have some kind of education or some kind of certificate of training. And then you would, you know, want to be supervised, and then you would have that information. And when it comes to labiaplasty, anybody's doing it. You got plastic surgeons doing it. You got general GYNs that have had no training.
Yep. Anybody can do it.
Problems that come along with the botched labiaplasty. But, you know, the guys and the girls, the guys and the gals that have had the training understand the anatomy and the flow. Like yourself, you've been trained with Dr. Matlock. I mean, you understand the anatomy. You understand the flow. You know how not to hurt a woman and leave her with forever scars that she can never get rid of, you know? And so there are people out there that are promising that they can do these labiaplasties for patients, and they don't have training. They don't have a certificate. They haven't been proctored. I mean, so I think one of the messages we need to get out there is that, one, if you're going to have this procedure, find the right person. If you're in Jamaica, you go to the Jamaican king. No questions about it. You go to Daryl because he's been trained. He's been trained by the Godfather himself. This is the person you want to do your labiaplasty. You know, you may think you save a few dollars if I have my general OBGYN do it, but then, my goodness, when you look down there, it may not be that pretty anymore. And then that becomes another problem, and that just makes life even more difficult because you've been frustrated with large labia for so long. Now you get it done, and it looks horrible. I mean, that's not a great trade-off. So women need to understand, find the right surgeon for the job. Make sure you interview them. Make sure you look at their website. Go to Real Self. See if they have answers to questions. Do they seem knowledgeable? And then come in and interview them. Ask them questions that you want to ask. And make sure you have the right person doing it. Because this procedure is pretty much a one-time go. On some of them you can revise, and some women you can't.
Have you had women come to you for revisions and they can't do anything?
Yeah, absolutely. I've gotten that where you can't do anything, and they're having some pain syndromes. And, you know, generally with those patients, we have to just start off by, you know, educating and showing them the anatomy where things have kind of went awry. If there's pain syndromes, then we compound medications, and we think about, you know, forgiveness. Forgiveness, not for yourself. You're doing the forgiveness for yourself, but you're forgiving that surgeon who has done this to you, because you're still a wonderful, healthy, attractive woman, even though this unfortunate circumstances happen. So yes, I usually counsel kind of along those lines, and I also provide, compounded medications if they are having some discomfort and pain secondary to the poorly done labiaplasty.
Great information. Great information. All right. So, do you like for your some patients? We spoke about this last night, but I just want the general public to know, because some women will come and women are just obsessed with tightening the whole vagina. And when I explain to them that the introitus, or the opening of the vagina, is 75% of sexual gratification, and not all women need a full vaginal repair. And some women can just get away with a perineoplasty. Do you agree with that statement?
Yeah, I think that's true. And in some cases, I think that is very true, that rebuilding the perineum. I mean, you can kind of tell from the history. I mean, if they need inside tightening, they may describe that once I become more aroused, I don't feel anything anymore. I don't feel any full pressure. Or, I just, the perineoplasty patient is saying, I feel them, but it feels like maybe he's falling out more often, and those kind of things. So then if that happens, then perineoplasty is the way to go, and you rebuild that perineum, rebuild that angle of attack, and you can tremendously help women to regain that prowess in the bed. So
Yeah. Michael, talking to you, you have so much knowledge, man. Like it's mind blowing to me. Like things that I had to figure out for myself, and I'm hearing you saying it, and like, oh, that means I was right.
Yeah.
No, you really have a lot of experience, bro, and I really admire the work that you do. I'm a fan. I did my research on you, and that's why I reached out to you. I'm a fan, man. I'm a fan, and like, as I said, there's not really a lot of us in the world right now. So I have to ensure that patients know that they're choosing the right surgeon, and they do the research. Patients always want to show me the work that you've done. Patients love to see pictures. Show me the work that you've done. Show me what you've done. I want to see it. I have a folder on my iPad with just pictures of what I've done before and after, showing them, okay, you want it like this? Okay, you want it like that? This patient said she wanted, Dr. Matlock calls it the bikini. They want it like this, the bikini. The bikini is basically a labial arm amputation. You want this? You want that? You want this? How tight do you want to be? 2 fingers, 1 finger? What do you want to be? Tell me and show me which one of these you like.
Yeah.
Yeah. People want to see things, that's how they judge your work, That's how they judge. I always tell patients, and I always tell my younger doctors, that when you do a C-section, a patient will look on the cut, and based on how that cut looks, they can, in their head, they will know if the surgery was done good or bad.
Yeah.
So the final product is what really matters for the patient.
Absolutely. Yeah.
That's what it matters,
Absolutely. I totally agree with that. Yeah, for sure. You're right on with all that.
Okay. All right. So, do you do a lot of work with combined procedures, or are you a one-man band?
What do you mean? I mean, all
right. So, like, for example, I do a lot of mommy makeovers, and I work with other surgeons who do liposuctions and breasts, and I'll be doing the vagina. I usually do my part first, and then the mother will do the liposuction and 360 lipo, or do you just do your part alone?
I just do my part. I'm an expert when it comes to that. So I want patients to know when they come see me, they're seeing an expert in labiaplasty, vaginoplasty, perineoplasty, majoroplasty, menopausal health. They have an expert that can accomplish their goals. I don't need to be a master of or know how to do a whole bunch of things. I don't need to learn how to do a whole bunch of things. I need to be a master, a guru, a goat when it comes to plasty, vaginoplasty, and everything related to female cosmetic surgery. So I want to stay in that particular lane and let patients know that they have an expert when they're seeing me. So I don't here doing breast dogs and lipos and BBLs, because then I won't be an expert. I'll be a jack of all trades, in my opinion.
I agree with you wholeheartedly. I like to stay in my own lane. I want to perfect my art. I'm still in the art of perfecting. I don't think I'm that bad, you know. But I'm aspiring to be like you. I'm aspiring to be like Dr. Goodman. I'm aspiring to be like Dr. Matlock. You know, that is my thing. I don't want to. I want to just focus on cosmetic gynecology. That is my dream. My dream is to be where you are.
Mm-hmm.
Like I want to, if I'd love to, but Jamaica, we haven't reached that. In Jamaica, we haven't reached that level as yet, you know, because patients still want me to be their gynecologist. Patients still want me to be their obstetricians, you know, and I'm going to break a lot of hearts, Michael, if I say I'm going just cosmetic. But that is where my true passion is. I'm being honest with you. That's
Yeah.
what I love.
I've seen some of the comments down here saying, Doc, make sure you do both. Don't stop. Don't stop doing I've seen
Yeah,
that.
that's the thing, you know, and I'm going to be honest, and a lot of patients are going to hear this right now, but we spoke about this last night, and I'm obstetrics is draining, guys. It's draining, ladies. You guys are draining me.
Uh,
It's hard to get up 2 o'clock in the morning and spend 12 hours with somebody to deliver the baby because everything else stops. You have to stop whatever plans. You have to go to the bank. You have to do this. You have to go to work. Everything stops for that patient, you know? And it's hard. I still love it. I still do it, but it's physically draining. It's
but
physically draining.
at the same time, it is so super rewarding. I
It
mean,
is rewarding. It
you're
is.
that is special. You're in a place that not everyone is able to experience, and to be able to just watch a young lady develop into a mother and true womanhood is just an amazing process. I do truly miss it. I am forever grateful to all the women that have allowed me to participate in their care. As you say, though, I mean, people are people. We get older. You know, it's hard to get up in the middle of the night. It is hard,
Right. It is.
but
It is.
appreciate it. And but at the same time, I'm still happy to be where I'm at now. I feel like I'm giving back to women something just as rewarding as it was to deliver them. And so I get the same feeling that that warm feeling in your heart when that baby screams for the first time. Well, I get that same feeling now when that woman calls me and says, "Oh my goodness, Dr. Reed, sex life is back to where I wanted it to."
Yeah.
Oh, my goodness, I've been so ashamed and bothered by my labia for years, and you were able to design, and we were able to design it and get it the way I wanted to, and I'm so grateful. That gives me that same warm feeling.
Definitely. You know what's my joy in obstetrics? My biggest joy is when I see the mother and the spouse, the mother, the spouse, or the father, the child, all of them together, and everybody is happy and healthy. I said, "Thank you, Jesus.
Yes.
I did a good job." I was telling some friends last night, before every delivery, you know, before every surgery, I pray, you know. Before every delivery, before every surgery, Michael, I pray and I said, "God, just please let everything go the way it's supposed to go. If it doesn't go the way before it's supposed to go, just give me the mentality to be calm and approach it logically, and I just put everything in your hands, Jesus. Everything, every delivery. That is how I approach whatever it is. I cannot function without praying before. It's such a big part for me because people take it for granted, you know.
Yeah, it's so true. I mean, every patient before I do surgery, I say, "Lord, I know I've done the work that I'm supposed to, but be there, guide me,
Yeah.
keep me on point." And I say that pretty short prayer just about before every procedure. Because I
Yep.
want him right next to me, and I want him proctoring me, and I want him to say, "Whoa, wait, don't you see that over there?"
Mm-hmm.
And
Even for minor procedures
done
too.
great. He's done great for me. I'm happy to have him in my life, and happy to just be able to have someone like that in my life. And so we're singing the same song and preaching.
Bro, we're brothers from another mother. You understand? It's my biggest thing is patient satisfaction. I'm not going to be happy until the patient is happy.
Mm-hmm.
You know, and whatever it takes, you know, sometimes I will jeopardize finances, I'll jeopardize time just to make that one patient happy.
Mm-hmm.
That is my goal, you know. My goal is ensuring that the patient is happy. And so, you know, Dr. Daly was there for me. Dr. Daly did this for me. He was approachable. You know, things didn't go the way it's supposed to go. Things went the way it's supposed to go, and he was always by my side.
Absolutely.
That is my duty as a female physician, to ensure that the patient trusts me and know that I am there for them. And if anything goes awry, I can pick it up and rectify the problem sooner or later if it does, you know?
Absolutely. Yeah, for sure. I'm in total agreement. You're saying the same things that I've said for years, and so we're both.
Humility is a thing, Michael. Humility is a thing. A lot of doctors aren't humble.
Yeah, but hey, we're regular people, just like our patients. We have feelings just like our patients. We have expectations just like our patients, and we know that we're not perfect. But damn it, we're going to do one hell of a job for you, and we're going to do our best at it. And
100%. I agree with you. I agree with you wholeheartedly. Anything else you want to shoot out? I think the time soon
yeah,
run out.
I think it was an honor and a pleasure to be here to speak with you. I want to shout out to Jamaica. How's everybody? I think it's wonderful that they have a physician in their country, the Jamaican King. He's going to start calling himself the Jamaican King. That'll be his new handle, the Jamaican King. You need gynaecology, you need cosmetic gynecology, whatever you need, the Jamaican King has you. And
I appreciate that, sir.
in hands, and I look forward to one day visiting you in Jamaica and hanging out there, and you know, just interacting, maybe just having a drink together and just hang out.
Of course, man. It's going to happen. You know, I'm a big fan. Like so in my residency, I was a big part of ACOG. I was the vice chair and the chair for junior ACOG. I'm currently the incoming chair for ACOG West Indies. So COVID really hurt me because I love to travel and I love to interact with other gynecologists. I like, people always call me, Daryl, you know anybody here? You know anybody here? I say, all right, let me do some research. And most of the time, if I don't know you, I know somebody who knows you, and I can get to you. And all of that was done by traveling. I'm a sociable person. I love to network. I believe in strength. Strength is numbers. I don't believe in any competition. There's no such thing as competition. We're all one family. You know, I only compete with myself. You know, I look to you. I look for others for advice. If I'm doing something wrong, I want you to tell me, oh, Daryl, don't do it this way. You know, you can do it that way. You know, I'm open to critique. You know, and I take pride in being that kind of doctor and individual. And I like to meet people, especially people in my field, like you, like Vagina Whisperer Las Vegas, like Dr. Matt, like Dr. Goodman, the Pelosi's, you know, all these guys I have in high regard, because this is a truly specialized field. And people really don't know how much intricacy it is. It's very intricate, you know.
Absolutely.
It's very intricate, it's very detailed, and I always tell people there's a thin line between cosmetic gynecology and urogynecology. You don't think so?
Thin line?
No?
I don't know.
I always call them cousins.
Yeah. Well, yeah. I mean, yeah. I mean, I think, yeah, we are cousins with the urogynecologist. Absolutely. Totally agree. I was going to point out, one of the patients of yours already updated their contact phone to the Jamaican King.
So it calls, Michael.
Yeah.
But I want to thank you so much, my brother. I can call you that right now. It was a great experience. We can plan out some future and we can attack certain topics, because nobody's really doing what we're doing right now. You know, nobody's really talking about cosmetic gynecology, and I can sit down and talk for hours about cosmetic gynecology. That's my love. That's my passion. You know, I can sit down, and we'll definitely have to do this again, and we'll have to, we'll come up with a schedule, and we can attack certain topics, you know, complications, procedures, everything. We can take it on, and we can make this a series.
Absolutely.
Pineapple turnover, send me another email again. I reply to every email. ddaily@3dgyna.com. Don't DM me. Don't DM me. I don't answer DMs. Right? So just send me ddaily@3dgyna.com. If I haven't replied, check it junk. Send it again. But Michael, thank you so much, my brother.
Thank you. It was a pleasure. I got comfortable. I stopped sweating, so didn't need that rag after all.
We're going, and I know one day we're going to meet up, and we're going to just continue this friendship, you know.
Absolutely. I look forward to it.
And I know I can, if I have any problems, any concerns, I know I can call you. Any second opinions, I know I can reach out to you, and you can give me some advice. You know, you being the guru, you have so much more experience than me. I mean, I look up to anybody who is above me and is willing to give me information or advice.
Yeah, I'm looking for some tips and tricks from you too, man. I can learn from everybody. So I'm appreciative of the friendship, and I look forward to it growing. And you know, hopefully my wife and I come out and visit.
Oh, you're more than welcome anytime, man. Anytime. We can plan it out. I'm here for life. I'm not going anywhere.
All right. The
All
Jamaican.
right, man. Take care. We'll talk. Thanks again.
Thank you.
I'm gonna save the life, everybody. So take care.
Thanks for everyone.
All right, man. Cool.
Bye.